Welcome to the Better You Project, optimizing health, hormones, and aesthetics. And I have literally one of my most favorite doctors I got to meet, last year, I think. No, the year before we met. And so I've got Dr. Stephen Ellis on the podcast today. Dr. Ellis is conventional medicine turned rogue. And I say come to the bright side, not to the dark side, because we're really the bright side here. He's woke. Woke is what I say. So Dr. Ellis is trained anesthesiologist who runs a med spa / now wellness center in South Lake, Texas with his wonderful wife, Sonia, who is an amazing trainer if you ever have an opportunity to train with her. But Dr. Ellis and I are going to talk a little bit about kind of some of the transition rooms from going from the operating room into integrative medicine and just kind of some of the training he's been doing. This is going to be a great addition to his med spa with his wife. And so let's get started. You ready?
I'm ready. Let's go.
All right. First of all, let's get started with, how did you start in anesthesia?
So, well, let's try and make this relatively short because it's a long story. I was originally going to go into orthopedics. Weird, right? When I was 9 years old, my mom had a bunch of back surgeries and I got interested, and we were in London at the time. So I got to see one of the most prominent back surgeons at the time on Harley Street in London. And he was like, yeah, come see it. We'll see how this goes. You can leave whenever you want. I stayed for the entire 5-hour surgery, and that really got my kind of claws into medicine. Fast forward, I went through 2 rotations in orthopedics as a fourth-year medical student, and both of those places were like, yep, absolutely, apply, you'll get in. Well, I didn't. Right. And so I scrambled. I got into a preliminary surgery residency. And it was during that time I was like, started to look on the other side of the blue drape. And I was like, yeah, I don't want to do this. It's funny, right? I do clinic now, but I was like, I don't want to do this clinic thing. I just want to do the fun stuff, which is procedures. And then I just want to go home. And then I got lucky because my program director knew one of the big program directors in Houston and called her up and said, hey, can you do me a favor? Can you interview this guy? And she's like, I don't really have any spots, but just send him. And at the end of that interview, she was like, do you want a spot? I was like, I thought you didn't have any. She goes, I love you. Come play. And so I got into anesthesia and I've loved it ever since.
So, which then brings me to my next question. Why the shift out of anesthesia and into integrative medicine?
Who wants to take call for the rest of their lives, right? I mean, as anesthesiologists, when we're on call, it's usually 24 hours, but we're beholden to different surgeons. So if a surgeon comes in and does a case, he's gone, right? But if there's like 6 surgeons lined up, you're stuck. You're still working, 24, 30 hours. And it was about probably when I got into my late 40s, I'm now 52, but late 40s, it really started to kind of wear on me, right? And then at 50, I was like, I just can't do this anymore. This is ridiculous. So my wife looked at me and she said, hey, it was sort of right around when COVID happened. We had a hormone place, I won't name who, next to us who never shut down. And we were like, well, what the heck? And we found out that they were considered essential. Mm-hmm. So we wanted to kind of figure a way, how do we keep our doors open, right? And keep paying our staff and all that good stuff. And she looked at me and she goes, you have since 2001 basically been doing functional medicine on yourself, right? Experimenting with, I shouldn't probably say this, but experimenting with SARMs and, all this kind of crazy stuff. And I was like, yeah, I kind of already know this. So I looked into A4M and I was like, let's do this. And they said, okay, well, it'll take you about 2 years to get through all the modules. I'm an overachiever. So 8 months later, I was done with my modules. I have my certification in all of those modules, but I don't have my fellowship technically yet. I've got to take my written. And then I was like, okay, let's go. Let's treat these patients. So I didn't want to just show up and be like, hey, I'm a doctor. I know this. I can easily handle this.
I applaud you in that, because there are many physicians who do, and then their patients show up on my doorstep, and I'm like, what is going on? And if you're a practitioner and you're listening, A4M is the Academy of Anti-Aging. There are lots of training programs that you can go to. Dr. Ellis went through A4M, which is the Academy of Anti-Aging, which is an awesome program. I went through IFM, which is the Institute for Functional Medicine. I think both are fantastic, top top two when it comes to training in integrative medicine. And so this is a rigorous program. This is not just a weekend course. There are different modules. So do you want to talk a little bit about that process? Only because I know that there are so many practitioners who listen to my podcast. And I know I've talked a little bit about my IFM training, but tell them a little bit about kind of the different modules you went through.
So I knew that we were going to do hormones kind of initially. And I was like, as a physician, even as an OB-GYN or what have you, really the only people who get hormone training are endocrinologists, right?
Right.
OB-GYNs.
And even that's not right. And you and I both know that. Even that shit's not right.
I know. So. And you got these OB-GYNs who might have done a month of something during residency, and I'm like, okay, well, if they can do it, I can do it. So I did the module kind of to dip my toes and get things going. And I was like, okay, that was good. And I did it, this is still when I'm working full time. I'm taking 24-hour call, working 30 hours, doing stuff on my drives, on the weekends.
Cold plunging, working out, testing shit on yourself.
All the crazy stuff.
Being an amazing husband to your wonderful wife, being a dad, doing all the shit. Yeah.
Yeah. I mean, as I do, I'm an overachiever.
You're so humble. Yeah. I'm like, I live it too. It's hard. Yeah.
It is hard.
Yeah.
And then it was, the module that kind of did suck. I was like, oh God, this is dragging on, was the cardiac module. I mean, that was just so much ridiculous information, but it's good. I mean, you pick little pieces out. Oxidizes LDL, ApoB, LP little a, all that good stuff.
LDL. Yep.
And then neuro, and I think then module 5 was kind of more along case. It was a case study module, how to kind of integrate this into your practice. Did GI, which was another good one about microbiome, right? Which they're all starting to come around to, right? It was, we were the funky people who dealt with the microbiome. You don't know what the hell you're talking about. We're just going to use Humira and all these, screwed up medicines that are going to mess people's systems up. And now they're like, oh yeah, let's talk about the microbiome. I'm like, well, functional medicine's been doing this for years. And then I think the last module was on longevity. So it was kind of all of those. And multiple lectures. You have to do the pre-module reading, the pre-module webinars. Mm-hmm. Then you have to do the module lectures. Then you have to do the post-module stuff. Then you have to take the test, and so it's not just something that you read a couple of articles and quote unquote, you're an expert. And I'm still learning. Hell, how many times do I reach out to you and go, Lexi, help? This stuff.
It's 1,000% true. And I'm so glad that you walked through that process, because again, you and I are both seeing this, when we go to conferences, we're sitting in the back together and I'm like, don't fucking raise your hand and draw attention to us.
But I love to do that. Just to screw with you.
It's true. I truly feel like we are scholars and we're going to be forever students. You're 52, you're a very well-respected anesthesiologist in your industry. And you are one of the most humble people I know, because you're not afraid to ask questions. You're not afraid to look stupid, and you're not afraid to reach out for help when you don't know, and vice versa. And I think that's what makes you such a great physician, is because you're always willing to go the extra mile, but you're definitely a forever student. And I think you can tell that. You can absolutely tell that. So if you are a practitioner and you are listening to this podcast, Dr. Ellis, I know he's going to be, offering some training through Sonia and their facility, but I fully intend me and Min and Carmen to go out there to do some work with you guys as well. But it's true. You cannot be an expert in 1 year of doing it, or even after you have your certification. I have a training academy and I would never call myself an expert. So I think it's very important to delineate when you are a patient and you're seeking healthcare from a practitioner, is how much continuing education are you doing in this world? Because it's always changing and we're always learning something new. Just like when you were getting ozone trained and you're like, hey, have you ever thought about using this in a vascular occlusion? And I was like, hey, I've actually thought about that too. And so it's so cool because you can start putting the pieces together and build on all these little pieces of information that you've learned. So I think it's great. I think A4M is awesome. I think IFM is great. So if you're a practitioner and you're listening and you are wanting to seek out education, I think my academy is great, but I think it's good as a supplemental to one of these certifications. If you're a patient and you're like, I need to find a good practitioner, I would try to find a practitioner who has taken these courses. These are rigorous courses. There's case studies, there's lectures, there's research, it's evidence-based medicine. This is not just some fly-by-the-night situation. This is the real deal here. So I think that's good. Let's shift gears now into talking about, so you're kind of phasing yourself out of anesthesia. Sonia's got this booming med spa, the L.A.B med spa. What like, tell us, like, okay, so you're like, all right, I got to keep this shit afloat here. I'm going to start adding in hormones. So talk a little bit about that. Like, did you just start like, okay, I'm going to just start treating men? Did you start treating women? I know Sonia has also kind of donated her body to your learning. So this way you could do that, which is, my husband has as well. So like, how did you get started in that part of it?
We really started more along the lines, primarily most women who go for injection. Most people who go for injections are women, right? We know that.
Right.
So I really started more, and I tell you what, you want to talk about complicated shit? Women, we all know you're complicated anyway, but when it comes to hormones, I'm like, oh, good Lord, could you make this any more difficult? So that was really where I felt that I needed to do the education. But so it was kind of dealing with some of these women who had gone to some of the corporate places, and they just felt like they were a number. They were on a conveyor belt. They were just kind of thrown in, and then there was no follow-up, right? It was, let's start you on this. And I asked him, I said, well, when was the last time they checked labs on you? And they're like, what are you talking about? I'm like,
right.
Well, hang on a minute. They started hormone therapy and they never checked labs. And then the men's side of stuff was kind of the same thing. It was the wife of, one of Sonia's patients, her husband, was screwed up. His testosterone was like 1,700. He was getting bled every month because his hemoglobin was 18 plus, and he was bloated, and he was always working out, and his hair was, falling out. And that's kind of when that's how I got into that. Now, I was sort of doing it on the side because I was still practicing 100% as an anesthesiologist. So it was very hard for me to be there. And it wasn't until really, we had PAs, we had nurse practitioners, and they kind of came and went and never really did what I wanted them to do because I wasn't there overseeing it. And then it was January of this year that I came and really started it full bore. And that was, we introduced the weight management side. Obviously, we know, right, semaglutide and tirzepatide has completely changed that landscape. And I'm not just using that for weight management. We've had that discussion before, right? Inflammation and stuff like that. That's a tough sell for some people. They're like, well, I don't, especially guys. Well, I don't want to be on that. It's a weight loss stuff for women. I'm like, no, it's for inflammation and your cholesterol and your uric acid and your homocysteines all through the roof. Let's bring all that stuff down. The
recent text that you and I have been sending back and forth about cardiovascular benefits and LDLs and all those other things, the heart protection piece of it too. So let me ask you this, because I think this is going to be a great topic for practitioners who are in aesthetics, dipping their toe into our world.
Yep.
Do you think it was a hard transition to take those aesthetic patients and make them wellness patients? And then I have a second part of that question, because I already know the answer is going to be, hell no, it's not hard to do that. What would, like, if you had a piece of advice to a practitioner who's like, okay, I have this booming med spa. Do I do it myself? Do I outsource it? Do I hire someone in? Like, because you've seen it from all the different angles as the owner, the main practitioner, and then not only that, like the overseer as the medical director. Like, can you elaborate a little bit more about that?
Okay, so is it difficult to convert those patients? No, but you have to educate them in the sense that the way that we tell patients is I make them pretty on the inside and Sonia makes them pretty on the outside, right? But you can't look pretty on the outside unless you're pretty on the inside, right?
Right.
You can have a phenomenal tablecloth, but if the table underneath it is shit and it all falls down, it's just a crumpled mess on the floor, right? So having that kind of discussion with the patients and educating them that this is not just me coming in and throwing a bunch of supplements at you or putting some pellets in. This is us optimizing you, right? Getting you. And I always, my sister-in-law always laughed. She was MAing for me for a little bit. And it was this patient I had in, and I said, the way I optimize is not like a lot of these other places. I said, my goal is not to make, I mean, she was in her 50s. I said, my goal is not to make you a 17-year-old that wants to go have sex with a lamppost. My goal is to make you feel good about yourself and your skin to glow and all of this good stuff. And so that the treatments that my wife's doing or I'm doing in the laser room are gonna stick, right?
Right.
And then as far as if you're a busy practitioner, I mean, if your hands are always full with syringes and needles, you're not going to have time to do what I do. There's no way. I mean, can you do it? Yeah, you can do it, but you're not going to treat your patients right, and it's going to be a disservice, and you're really doing it just for the money, which is not the way to go, right? You never do that in medicine. You don't do it just for the money. You do it because you love it. And if you do it for the money, you're never going to be successful, or you're going to be miserable, right? So it's either find someone that you can kind of partner with, or find someone who maybe you can bring into the practice who wants to start doing injections, but they have this sort of background, and you can introduce them that way. And then that's the way to do it. I mean, if you try and do it on yourself and you try and do the education, I can tell you it's rigorous. I mean, that 8 months sucked.
It's like a postmaster's degree. Like I have 2 master's degree. It's like another postmaster. I think it might have been actually harder. So kind of having said all that, I think that is so important, because I know that, again, there's practitioners who listen, I think that's great that you're going to be adding in wellness to aesthetics, because it makes sense, right? Just as you said, Sonia's going to help people on the outside and you're going to kind of fix what's on the inside. It makes sense to marry both of those modalities. However, just as you said, if you as the practitioner and the business owner are not going to dedicate the time to invest in the education part of it, it's totally okay to hire someone in and say, like, okay, you're going to be like the piece of that, or kind of the driver of it, because I think it's hard when you're trying to carry both hats. Now, for me, I'm doing the opposite, right? Like, I came from functional and I added in aesthetics, which was actually really also easy for me, because it just, as you said, you're just educating them. Like, I'm not trying to sell you anything. I'm just trying to teach you what's going on with your body as you develop symptoms and you get older. Like, we're just trying to educate you. And as we learn different modalities, we kind of learn different pieces. Like, oh, I see your TPO antibodies are this. Let's talk about removal of gluten. Let's talk about low dose naltrexone. Let's talk about selenium and iodine. So it makes sense, right? But I think it's so important to understand that when you're owning the business is that you're either going to have to dedicate the time to actually learning it, or hire someone in and groom them to run that section of it. Because I see it's already starting in this industry, and patients will be like, well, I was getting my Botox at this place, and then I started on these pre-filled syringes of semaglutide, and I just feel like I'm plateaued, or I stopped going and then I regained my weight. And I'm thinking to my mom, like, yeah, because you lost muscle, because they weren't looking at in-bodies, because they weren't tracking your protein, because your testosterone's probably not fucking optimized. So I'm like, in my mind, I'm like, yeah, because they weren't doing all this other stuff. And so I think it's so important, just as you said, you have to focus on all these other things and not just the pretty pieces of medicine.
Yeah. And now you can go, I didn't know if you saw this, you can go to Costco.
Yeah, I saw that.
Seriously, for $179 subscription and possible Ozempic or Wegovy, I'm like, okay, it's not going to be $179, people, right? Because you can't get the medicine for that price. And plus, you're not going to have the body composition following. And they're probably not going to educate you on how much protein you should be taking, right? They're probably
amino acids, perfect aminos, leucine, isoleucine, like all the branch chain, like all those things, or adding in other peptides, kind of thing. So, I think, so Dr. Ellis got to come shadow me for 2 days. It was like September, August, I don't know, it was the summer last year.
I think it was August last year.
And it was so cool, because it was a way for him to kind of see, like, okay, he already had the knowledge was in there, but it's like, okay, how do I see these moving pieces kind of layer on top of each other? Okay, they're there for a repeat pellet. Let's review their labs. Okay, are there any FSH changes or hormone changes that we got to address? Okay, they're on semaglutide. Let's look at their in-body. Oh shit, they've lost muscle. Okay, let's layer in maybe some testosterone on top of that. Let's also add in maybe some BPC 157 to help their recovery, or get them in with the health coach so they can kind of help us. But it was really cool to see kind of how all those moving pieces play such an integral part to the holistic experience of getting patients better.
Well, and I have to say, thank you for the stacking info, right? Because I've had so many people come in and they're like, well, I need my pellets. I'm like, no, you're at 100. You're good right now. You're good for another month because I don't want to stack you. And they're like, well, what do you mean stack? Right? They come from places where every 3 months you get your pellets. And then they wonder why their hair's falling out and they've got acne again.
Or their clitoris is huge.
Yeah.
So stacking, if you're a patient and you're listening, or you're a practitioner and you're listening, stacking is where, if you're getting testosterone pellets, for example, and the levels have not fallen down. And so pellets theoretically should last anywhere from 3 to 4 months on a female, 4 to 5 months on a male, just depending on how active. Pellets are released on cardiac output. So the more active you are, the more the release is going to happen. So what Dr. Ellis and I would look at when he was shadowing is where was their peak levels, and if they're kind of riding above where our optimal is, even if they're close to that tier, I'm going to lower the dose 1 to 2 doses below that because I don't want them to stack. I want them to stay at an optimal level. And I tell patients this all the time. We're very good at what we do, as I'm sure you are. And so trust me when I tell you, we need to lower the dose because more is not better in this situation. But yes, absolutely. And I think drawing labs and going off of symptoms, I think is so crucial when you're monitoring these patients. Like these are endocrine treatments. And so we can't just be like, oh, here's your pellet and I'll see you, in 6 months and we won't get labs again. It's like, no. You gotta monitor this. So we chatted a little bit about semaglutide. So I'm going to kind of just pivot here a little bit. Semaglutide in anesthesia. Let's talk a little bit about it, because when you were shadowing me, we had an awesome opportunity where a patient was coming in. I think she was getting like a hysterectomy, and she had asked me about when to stop her semaglutide. So you were at the front line of this. I think we had said maybe 7 days, but you're like, I don't know, maybe even longer. So tell us what were you seeing? So semaglutide mechanism of action is slows down gastric. Yeah, go ahead.
Slow down. Well, I mean, it depends on where you want to go now, because if you look at the literature, they're starting to think that it's more brain driven than gut, right? That neuroinflammation study that came out with the rats, which I thought was fascinating, right? Mm-hmm. But yeah, so slows down gut, decreases hunger, increases feeling of fullness and all of that. How does that affect us, as I guess what you're saying, as someone who's coming for surgery? And it was really, no one knew, right? Initially, when all of this kind of blew up, there were no studies, there was no follow through. No one thought about, how is this going to affect, us? Because, I mean, we're just the person who pushes some white stuff and you go to sleep and wake up and it's magic, right? And so I was kind of at the forefront for our group, because I was a medical director at one of the surgery centers in this area and had to come up with this. And I'm like, great, I have no guidance. And of course, you're fighting surgeons who just want to do surgery. Mm-hmm. They don't really think about this stuff. So I talked to an endocrinologist about this when I went to a talk on Mounjaro when it was just coming out. And he said, because I told him, I said, okay, what our society is basically saying is stop it for a week, right? And then that's it, you're good. And he was like, well, it doesn't really make sense, right? Because it's 4 to 5 days half-life. So realistically, it's not out of the system for 3 weeks. So stopping it for 1 week's not really going to do anything.
Right. It's not going to do a whole lot.
If you've got people who are diabetic, you don't really want them to skip a dose. Now they're 2 weeks without a dose. So how do we do this? And he and I sat down and talked, and I talked about the mechanisms and intubating and what that involves, and aspiration pneumonia, all the bad stuff that puts you in the ICU, potentially kills you. And it was 24 hours clear liquids we thought would be the best. And we've now changed that. I've diminished that to 16 hours clear liquids, but with a light meal before, right? Because even you think of it like a pregnant patient, right? Pregnant patient has decreased gastric motility, and you want to decrease what's in that stomach so that when you put them to sleep and you reduce all of that protective mechanism from the stomach to the airway, you want to make sure that nothing comes up, right? Or if it does come up, it's liquid, it's not food, right? Food's the worst thing you can do. Right. So now we're doing 16 hours, but I mean, cases are still. So
do you skip the week before dose at all then?
I don't see any point.
Okay.
I really don't see any point. because you would really have to stop it for 3 weeks. I mean, it's going to decrease over that time period, right? So if you skip a dose over that 2-week time period, you're not going to have as super physiologic levels of GLP-1 as you would if you didn't. But really, it's making sure that everything's gone through. So people are going to be like, okay, well, what does that mean? Most of the time I'm told not to eat after midnight, right?
Right.
So I don't know what 16 hours necessarily is going to do. So the studies have shown for years, right, you really need to have an empty stomach from food for 8 hours minimum, right? Well, if you tell someone that and they have surgery at, 10 o'clock, I mean, potentially they're going to eat at 2 or 3. If they eat at 3, then they get pushed back. Clear liquids, it's really 2 hours. So really doing it for that 16 hours, you've doubled the time for stuff to move on through, right?
Yeah.
But if you have GI symptoms day of surgery, right? You've got nausea, you've got bloating, you've got all of this, then most of the time the anesthesiologist at that point is going to probably cancel you, because even with that 16 hours, you're still not cleared, right? And you're still having issues. So just know, I mean, for the patients out there who are going to have surgery and they're on GLP-1s or the dual agonists, right, that they should think about maybe calling the morning of if they're having GI symptoms and say, hey, before I head in, do you think that, the anesthesiologist will put me to sleep, and they can have a discussion with the anesthesiologist and maybe save everyone some time, and then someone else can have that slot for surgery.
Yeah. What about colonoscopy? Because of the slow gastric emptying.
So colonoscopies are actually relatively easy from that standpoint, because you're doing a prep and you're on clear liquids.
So you're like on the clears basically.
You're on clear. So colonoscopies are super easy from that standpoint. Now, you still have an increased risk, because with a colonoscopy, we're not protecting the airway, right? We're not putting in a breathing tube. You're breathing on your own. You're under heavy sedation with propofol usually. And you're losing that ability to protect your airway with decreased gastric motility. You may still have liquid, which means it may still get into your airway.
Yeah, no, it makes sense. Another thing that we see tons on the functional side, because we do hormones and thyroid and cortisol and gut, hair loss. Talk to me a little bit about post-anesthesia hair loss. Is it a thing? Is it not a thing? How long does it last? When does it show up? Because I feel like this is a question I literally get all the time. And I'm like, phone a friend, Dr. Ellis, help me. I don't know the answer.
So this is funny that you bring this up. There's always a joke in the surgical suites, right? Anesthesia gets blamed for everything.
I always say pellets get blamed for everything too. So go ahead.
So we get blamed for absolutely everything. So after you asked me this question, I kind of asked because I've never seen it, right? But then we don't talk to patients. I mean, really, once you've left that day, I mean, unless there's like some major, we're like, bye, don't call me, I'll call you, and I won't call you. So have fun with that. There's really no follow-up for us from that standpoint. So it's the surgeons usually see that, right? And I can tell you the surgeons are going, yep, that's anesthesia's fault, right? Where it's not. There's no mechanism that really makes sense. They claim because anesthetics slow down cell turnover that it can affect it that way. Okay. It's usually because of the stressors from surgery itself, right? Okay. And so, basically the hair follicles stop producing new hair becomes weakened, it falls out, usually 2 or 3 months after surgery. They call it telogen effluvium. Yeah, right?
Telogen effluvium, yeah.
Right. And it usually fixes itself, and it can be after any stressor, right? Divorce, significant loss in the family, major surgery, major infections, or anything like that. Hormone changes. I mean, we all know, right? People who come in with issues, GLP-1s, right? Anything that's really an added stressor on the body can cause it. So I think that the hair loss is more because of the surgery itself. We just get blamed because we're easy to point the finger at.
Yeah. Yeah. No, it makes sense. No, that's helpful. I had a patient who asked me this question, and I'm like, I'm actually doing a podcast with an anesthesia. I'll ask him. But one of the other questions she asked, and maybe you have some insight to this because of your integrative background, is, so like, would you do like any kind of like detox program after like surgery with them, or would you recommend something that has like anything like a glutathione in it, or any kind of amino acid detox, or do you think that matters, or
No, I
not
think
really?
that like zinc, D, iron, biotin, things, even Nutrafol, right? I mean, if you want to take Nutrafol, that would be a good thing. And I don't know if I can talk about brand name stuff, but anyway.
Oh, this is not a paid CEU, but I like where your head's at. But no, you can go rogue, man. Go rogue.
Veggies, fruits, just eating healthy. And as far as you do want
get your
detox, right? Detox, liver support. I mean, that's primarily where all this stuff's going to go through, right? Everything that we put in your body, yes, it gets, like the gases are going to get breathed off. Propofol is via volume of distribution, and then you pee it out. But things are still going to go through the liver. So anything that's going to help, with that. So putting yourself on like a B complex, help with those methylation pathways, as you said, glutathione, really to support that liver, both in phase 1, phase 2. And just kind of thinking about that. But other than that, and there's nothing specific that you would come in and be like, okay, this is going to be your magic way to completely detox. So it's just normal stuff that we do to help people with, when I put them on the GLP-1s, it's the same kind of thing I'm doing. I'm like, look, you're going to lose all this fat. Well, fat contains all this inflammatory crap, right? And that's going to go to your liver. So let's support your liver. So it's kind of what I do. I would suggest that would make the most sense. Yeah.
No, I mean, makes total sense to me. I'm actually doing a podcast coming up in the next 2 weeks with a physician here in Indiana who has been doing a lot of research in BII, breast implant illness syndrome. Yeah. And one of my questions to her is going to be, so you and I know how fat can basically, it can produce estrogen, it harbors toxins, all these things, right?
Yep.
One of my questions is, if someone has had BII and they get the explant, would she put a fat transfer as the breast? Because I'm thinking you're going to be putting toxins on top of a fresh wound. I don't know. I don't know. So that is going to be something I'm going to ask her, because when I put my integrative hat on that, I'm like clearly her body don't like that. You know what I mean?
Well, and fat transfer itself is, if you don't get a good blood supply at that point, that's just going to be necrotic, right? It's going to turn into necrosis. You're going to have this big walled mass, and then they're going to have to wait for things to calm down before you're going to have it taken out, right?
Yeah.
So, I mean, it's a tough situation.
Yeah. Implants are just tricky in general. They're just really, really tricky in general.
Yep.
All right. Well, I think I got all of my really hot questions answered here. Any final thoughts, closing thoughts, anything you want to say?
I mean, I don't know. I mean, as you said, we could probably sit here for hours and hours and hours and talk about stuff. But, I think at some point, I don't know if you want to do this again, maybe go do something on local anesthetics. I'd love to talk about, procaine for neural therapy.
Yes.
But also talking about, everyone's doing these numbing creams and stuff, and what does that look like? Toxicity and injecting lidocaine, and how much can I inject, and all that kind of stuff.
Absolutely, and we can for sure do that.
Multiple rabbit holes.
I would love to see what you think about neural therapy, because it's been such a huge thing that we started doing in our practice, especially we started in the winter. So it's helped a lot of patients with seasonal affect disorder and things like that. And then I've started using it in scars, like scar therapy.
Oh, really?
Okay. Yes. And so I'm actually presenting on this at our mastermind in May 3rd and 4th, using procaine and ozone. Because they've taken many of my peptides away. So I'm left to some other devices. But when you look at modalities and mechanisms, ozone, that's increasing VEGF, right? Mm-hmm. So that's your vascular endothelial growth factor. And then Procaine is also helping with it's breaking up basically fibrous bands, you're resetting the ions. And so like you release that, but not only that, it does help with collagen and fibrin like turnover. So you're using it from kind of like an anesthetic, because ozone straight up burns by injection, in case you've ever done that before. So it's kind of like you're using it for that. You're using it for the mechanism of scar. But again, we'll save that up. And I think that'd be an amazing episode that you and I could both do some really good information on that. So Dr. Ellis, where can we find you, Peptide Poppy? What's your Instagram handle?
It's just Dr. Ellis _ the Lab Med Spa. Super easy. So if you just, I think I'm the only one out there, but if you put the Lab Med Spa in,
yes, I will. Don't worry, Dr. Ellis. I got you, man. I will link everything in the show notes. I will tag him. I will tag Sonia. I will tag the Lab Med Spa. What's your guys' website? If people in Texas want to come find you, come get treated with you?
thelabmedspa.com. So real easy. So, yep. But that's the way they can find me. And, we're updating the website right now, but we will be adding the functional info on it. But you can call the main number if you want to set up something with me or my nurse practitioner, Shelly, and we'll be happy to see you.
Okay. And then are you presenting? Are you teaching? Because you're always globetrotting with your wonderful wife, always teaching. So where can we find you there?
BeautyCon. So I think BeautyCon's in July, I think. But that's the next one that we're going to be presenting on. I think I'm doing functional and local anesthetic systemic toxicity at that one, or blocks. I might be doing blocks, which means I'll talk about toxicity. So I do facial block stuff too. So
yes, that's a good one.
Yeah.
Anywhere else that you're speaking that I need to know about?
I don't think so. I'm going to go do an ultrasound course, I think in June, with one of our friends, Loretta. I don't remember what her spa is called, but we'll be going to Florida. I'm doing an ultrasound course down there for her.
You're teaching the ultrasound course, right?
I'm teaching the ultrasound course.
I thought so. So that's one of my goals.
I just do so much crap.
Listen, I know, like, you got to go. You got to just give the people what they want. That's what Carmen says. You just got to give people what they want. I know. So Carmen and I fully intend to come out to train with you. Carmen will go train with Sonia, and I'm going to come train with you on some ultrasound things. And I don't know, get into nerd out. Just get all the cool stuff that we do.
We can play with the lasers. We can get an eggplant out and burn the crap out of an eggplant with lasers.
Sonia's going to be like, I leave you two alone for 1 minute. Like, just don't burn the place down. Don't worry. We got it. All right. Well, this has been awesome. I so appreciate you always taking the time to, partake in my nonsense. And I'm sure we will have you on for another episode.
Okay.